and welcome. This is the first in a three-part series that we are doing on the topic of depression and suicide. We are calling it Understanding Depression, the Suicide Connection. Back with me is Dr. James Jordan, who will be my co-host. He is the former medical director of the Ham Psychiatric Clinic in St. Paul, Minnesota, and the former president of the Minnesota Psychiatric Society.
Mary and I completed a 5-part series on major depression. While during that series, we realized that there was an aspect of major depression that needed our special attention, and that is the real possibility that someone with this illness may, in fact, commit suicide. We are approaching in this 3-part series both the prevention, the direct care of someone who has major depression, and then, if that tragedy happens, taking care of those who survive that outcome of this illness. Today's guest will help us discuss and address the clinical problems related to the care of someone with major depression.
We will be back in just a moment, and Jim will talk with the man who almost committed suicide. Please stay with us.
Welcome. This is an opportunity to talk to a man who has a very, very unique experience in that he is both a survivor and a victim, in the sense that he got this far away from taking his life through suicide. Mark Meyer is the executive director and founder of the Face It Foundation. He also is a clinical social worker, teaches at the university, in the Department of Family Practice, lectures. He's here to talk with me about his experience, what happened, what has helped him. Mark, tell us about it.
Thank you. Well, to cut right to the chase, I nearly died by suicide 12 years ago. And what led up to that, Jim, was a number of years of battling untreated depression and anxiety that eventually just took its toll. And for me, the option of dying by suicide in my head at that point was the best option I had. Mm-hmm. And of course, the irony in that is that I never actually had any type of formal treatment during the time leading up to that point. Mm-hmm. Like most men, I didn't want to deal with it. I didn't want to face it.
Is that a male thing?
Well, we know a lot about men when it comes to the treatment of depression. We know they don't want to go to therapy. We know they don't want to take the medications. We know they don't even want to acknowledge that they have problems. Mm-hmm. And when I nearly died, I mean, I've been married for 22 years. At that time, I had my wife of 11 years. I had 3 beautiful children. I had a big job. I was the administrator of a dialysis clinic at Hennepin County Medical Center. I had everything going for me. And when I came out of the hospital a few weeks later, and my story actually never really made it to my family for a couple of years, nobody could believe that I, the person who everyone perceived to have everything going for him, nearly killed himself.
Incredible. Tell us about the event itself. I was very struck by that.
So I was abusing alcohol, like a lot of men do at that point in their battle with depression. My wife is a nurse, and Jim, she had gone off to work, and I had made a plan about 3 days previous that I was going to take my life that particular night. I grew up here in Minnesota. I was a hunter. I have shotguns in my house. I had very easy access to shoot myself. Mm-hmm. I put my 3 kids to bed, who at that time were 5, 2.5, and about 9 months old. Put them to bed and figured out where could I put myself in my house so they wouldn't find me, so that there would be less mess to clean up. I distinctly remember, Jim, thinking how the whole world, particularly my children, were going to be so much better off once I actually did this thing. Mm-hmm. So I sat with this gun, and thankfully, my daughter, Ellie, woke up. She woke up crying. It was enough to get the gun out of my mouth, out of my hands, to go attend to her, hold her, care for her. My wife comes home from work, finds a gun, an intoxicated husband, and I was committed to the hospital.
tell us what people should do now based on what you know, what you've experienced. How can they handle things like this, men and women, but let's talk to men for a second.
Well, I think for men, the biggest thing is to realize you're not alone. In my organization, we focus specifically on men with depression. Every single man I've ever met who comes through our front door says nobody else knows what this is like, nobody else gets this, nobody else can possibly feel the way I do. And once they realize and they meet a group of other men, they realize they're not alone. And so I think for men, they need to understand this is not unique to them.
That makes all the difference, the connection,
Without
getting
a doubt.
in and getting help.
Without a doubt.
Mark, I want to thank you. We've had so little time to cover so much. Your message has been very, very important and clear. Thank you. I want to thank our audience. We will now be talking to a clinician about the treatment of depression and how to take care of that in the appropriate and necessary way. Thank you.
We're back, and with us is Dr. Anne Gearity. Dr. Garrity is a clinical social worker. She is in private practice. She's a consultant in the community, and she's also a clinical faculty member at the University of Minnesota in 2 departments, the School of Social Work and Psychiatry. Welcome, Anne.
Thank you, Mary.
As a social worker and clinician, you deal with people all the time who are very sad and people who are depressed in a clinical sense. And I think it's hard for many people to know the difference. Could you just start by sort of differentiating the
That's
two?
a good place to start, Mary, because sadness is inevitable. It's part of life. And we often get sad when things are stressful or when we experience losses. And most of the time we feel sad and we find ways to move through that to other feelings. Depression is really a persistent state. Depression is different from sad in that the feelings linger and deepen. Sometimes we talk about depression as pressing down of hope, pressing down of options. When someone is depressed, they often feel despair. They feel a sense of hopelessness. And very importantly, they feel a sense of worthlessness. It's as if their power to change their experience is so diminished that they can't see a way out.
So that worthlessness leads to hopelessness,
Yes,
wouldn't
and
it?
hopelessness leads to worthlessness. We all need to be active in our lives, and people with depression often feel a loss of that positive activity.
Would you agree with Dr. Garrity that the symptoms of clinical depression are the ones she mentioned, and do you have any others, Dr. Jordan, to add?
Certainly. As Mary just asked and Anne commented, the mood, the feeling of oppression and being pressed down, the change in one's outlook on life is an essential part of the feature of a depressive illness. But for a physician, for a psychiatrist, for a family practitioner, there are certain signs and symptoms that we look for. They are physiologic in the sense of disruption in life, functions in life, sleeping, eating, concentrating, being able to perform one's tasks in the usual way. Our topic for today, thoughts that one usually doesn't have, like despair, life isn't worth living, thoughts of suicide. Somewhat alien to most people, or all of us. However, they're there. They're an essential part of this condition, this diagnosis. So that, as you said, this oppressive pressing down factor, and then these physical, because it's a total body experience for someone.
So you can feel physically horrible when you're clinically depressed, right?
Absolutely.
I think a lot of people know you feel emotionally horrible, but maybe wouldn't always connect the physical part.
pain exists everywhere. And many people with depression are more aware of the physical pain, but because they can't identify it with something tangible, like the flu, it exacerbates that sense of mental distress and again powerlessness.
Why
It
am
also-
I feeling
Why am
this
I feeling
horrible?
this way? It also creates an incredible social isolation. It's not unusual for people who are feeling depressed and even suicidal to have the belief, they would be better off without me. I would be doing them a favor to be gone. So that sense of social alienation is just profound.
And one thing I want to ask you both, I've always been wanting to clarify, and that is that, as I understand it, you don't have to have a cause in your life to feel major depression, do you? It can come on kind of out of the blue, but it could be started by a true
Yes.
sad loss, too, correct?
There are certainly situational triggers. So loss of a loved one, loss of a job, change of life circumstances. But you're right, Mary, for many people it's a biological phenomena. Something happens within our bodies that changes, like any illness, that changes our sense of well-being or equilibrium. And that can be very confusing to people. They often talk about life feeling very dark, or their perceptions feeling very grim or gloomy, or again, that hopelessness that can be Jim used the word mood. It's like the temperature of their well-being just changes so dramatically, and they can't identify why. And then they go looking for explanations.
And it is pervasive, as we pointed out, in terms of your mood, your behavior, and your thinking. All
They
three.
can all be affected, right?
All three will be incorporated into this, and you'll see this change. There are precipitating factors, often work stress, military stress. We see that now in our veterans returning. There are circumstances of relationships and loss, sometimes bereavement. Normal bereavement can become a clinical condition, so that there are these dimensions of our day-to-day life that can precipitate. And then there is also the idea that we have some persons who have a disposition towards depression, recurrent depression.
Would that be a genetic condition in a sense, Dr.
Exactly,
Jordan?
yes. More and more evidence is showing that for a certain percentage of people, they have a recurrent major depressive illness. Bipolar disorder would be the common one that we treat and can treat effectively. And back to major depression in general, these are conditions that can be and should be treated. And that's really what we're discussing here today. What is the best practices that we can deploy to take care of individuals who develop this change in those dimensions of their day-to-day function?
Well, first of all, you've got to get to a therapist or a mental health professional or some kind of health professional, don't
Well,
you?
most people first get to their doctors,
True.
right? And they get to their internist, their general practitioner, with that sense that I don't feel well. So I think the first stage of treatment is to help everyone recognize that I don't feel well as a legitimate statement and not a failure of character or persistence. I don't feel well.
So don't just assume it's the winter blahs or, take it seriously,
Or
correct?
ask.
Or ask your
Be
doctor.
willing to ask. I don't feel well, and it feels more than the winter blahs. I think we have to really use others to help check our perception, because as Jim said, depression changes your thinking and perception.
But people don't like to think that they might be depressed either. So there is often denial, isn't there?
There is.
You know, this can't be happening to me. Don't most doctors think meds before they think therapy? Isn't that one of the places we may, in a sense, get hung up in the treatment part of depression?
That is, in fact, our practice in Minnesota and in the country. the practice is to prescribe medication for major depressive illness. And as a matter of fact, it is an important part of good practice to consider alleviating these symptoms by using the antidepressant medication class. However,
there's a big however,
there
isn't
is a
there?
big however. The medications have certain challenges when you use them. They take a while to work, can be
Quite
months.
a while, right?
Can be
For
months.
many people, quite a while.
That I think is important for people to hear, isn't it?
It can be months, it can be several trials of various medications. In the meantime, there is also evidence, very, very good evidence, that therapy, counseling, an opportunity to connect yourself with someone. And if you think about it, that if the feature of depression is to be withdrawn, the idea of having a connection with a therapist, a mental health professional, to help you through these weeks, these months, conceivably, while you are improving, and you will improve.
Yes.
The prognosis is good. But that is a very, very important part, and one thing that we wanted to very much talk about and emphasize with someone who does this sort of practice every day.
Do you feel that Jim says it can take weeks and months for medication to work? Do you feel that is true with the people you work with?
With many people. You know, there's some very interesting research about the power of medication. We know that the placebo effect is fairly high, so when people feel ill, they want to feel better. But for many people, especially with major depression, as Jim says, it takes a while for the medication process to alleviate symptoms. So they have to do other things. Now, that's why the social aspect of depression is so important. When you're feeling so disconnected from people, you tend to isolate your problem solving. So the first role of therapy in the acute phase of depression is restoring a sense of company. You know, you have
Someone to talk
depression
to.
and I can listen, I can help, I can make suggestions, I can, you know, challenge your perceptions of hopelessness and suggest other ways. We know that exercise, for example, is quite effective in relieving some dimensions of depression. But to ask someone to get up and exercise is really hard
When you're
when you're
low
feeling
energy,
so low.
it's
So sometimes you
people
need a coach, and a coach not just to say go run, but to really appreciate this tension within your mind about how to feel better.
We have in our state and in our country, of course, a real shortage of mental health professionals. And this makes it hard, I think, for people to find a professional that they trust and kind of click with. And even in rural areas, even find a professional. What do you both say to people who are facing that challenge of finding either a professional or the right one?
Well, Mary, the first thing I would say is that we've reified mental health. You know, we've made mental health something that is separate. Mental health is about physical health and my attitudes about myself. So we need a community mental health response that says when people are distressed, there are others who can provide company. And especially in some of the more rural areas, many people look to not mental health professionals, but other professionals or other people in the community with sensitivity and kindness. So we need to really respect that system.
Can we do a better job of working together, collaborating in terms of taking care of our patients who have major depression? Primary care is doing a lot of this work. That's where people go when they're not feeling well.
Right.
Physical complaints, the things that bring them to their family doctor. When they need medication, they need therapy, what are the kinds of things that we could do better to make sure that we take care of the patient as a whole but also collaborate better in terms of
You know,
this
one
practice.
of the most interesting initiatives of the Psychiatric Society is providing consultation to primary care physicians. Because I think primary care physicians provide a lot of mental health care.
They're kind of on the front line.
They're
aren't
on the
they?
front line. And providing consultation and support is a very effective and innovative model. I love talking to primary care doctors because then we're working together.
We have 1 minute left only. And there are so many populations that are vulnerable. But would you, because of your work with young people, just say a couple things about teens and suicide, Anne?
Sure, Mary. You know, I think the challenge with everyone with depression is that they lose perspective. But teens, by definition, have a very narrow perspective on life. You know, on the one hand, all teenagers feel like life is wide open and they can be anything. But when they're depressed, they really lose hope in a very particular way. My experience is that most teens don't mean to die, but tragically, many act in ways that cause them to die, and that really is a horrible outcome.
Thank you so much for joining us. I wish we had more time. I know Dr. Jordan agrees. But perhaps we can have you back sometime. Thank you for being with us with this segment with Dr. Garrity. We're going to take a very quick break and then be back for a wrap-up. Stay tuned. We're back now to wrap up. And Dr. Jordan, so many things I know you would like to comment on. What do you think, though, are the key things you would like viewers to take away from this program?
Mary, I will pick 3, although I would like to take more time and pick more than 3, but 3. Medication for major depression is important. And there are several things to understand that are critical about taking antidepressant medication. It takes a while to work, weeks, sometimes months. Several trials can occur before someone is feeling that they're on the right medication, that they can manage the side effects, that they're starting to improve. This needs to be monitored by the doctor that prescribed the medication, his staff. Could be a family practitioner who is in consultation with a psychiatrist if there are challenges there. But that's going to take time. You need to stick with medication.
But if a medication does not work, you have the option of trying another one.
That's right.
And there are lots out there.
There are lots out there.
As
there
we
are
see on
choices.
television.
Right. There are choices. Side effects of one may not develop in using another one. However, the idea of having a period of time elapse before you can make that decision can actually make a person's signs and symptoms worse. This is one of the reasons we invited our guest to join us today to talk about one of the important parts of therapy is to be supportive of helping someone while they're improving.
Or while they're waiting and not showing changes if they're not on the right med.
Their signs and symptoms are improving. They can have someone to spend time with, talk with. They can actually learn something about themselves, and they should if they're going through this type of experience. So that's one of the secondary and important goals of therapy too, that you can learn about preventing a recurrence of this in the future, looking at your life and so forth as you're feeling better. The irony of being depressed is you have to feel better in order to do therapy, to do good therapy.
Right, because one of the symptoms of depression is you're feeling such low energy, right?
That's right.
And it's hard to do anything right.
That's right. So there's a supportive phase at the outset, helping someone feel better, but as they're feeling better, then they can get into the understanding and possibly even insight. And that's what we're looking for as a combination of good practice when we do both of these things. The other point I want to make is the idea that talking therapy, psychotherapy, is something that is not necessarily easily accessible.
Right. There aren't enough social workers, psychiatrists,
That's right.
MDs that
That's
can
right.
be good listeners.
That's right. And you have to find the right fit. Now, family, friends, others, people that have been in therapy before, they can help you. They can give you referrals, names, and you need to take advantage of the possibility that there are options here. It is difficult in certain parts of, let's say, rural Minnesota to find access sometimes to psychiatrists and to therapists, but taking advantage of others and others' experience can get you into that type of consultation. Very important to have it, and as soon as possible.
And you need to really, though, listen to yourself, don't you, and say, this person I've gone to for help either doesn't click with me or I don't feel we are working together right, and be brave and change and ask for another or look for another therapist, right, or another practitioner.
That's right. That's right. And while those conversations are going on, you want to be paying attention to the fact that someone will ask you about whether you're having suicidal thoughts and feelings or not. That is part of being depressed, and as they diminish or improve, those are signs that you're getting better. Things are getting better.
We'll be back next week talking to family members whose loved one committed suicide. We hope you can join us for that, and thank you for watching today. If you're feeling desperate, hopeless, and/or suicidal, please call the National Suicide Prevention Lifeline. That number is 1-800-273-TALK or 800-273-8255.